Welcome to the Explainer. Today, we are building a super high-yield blueprint for pediatric hematology and oncology. And this is designed specifically for you, the busy PA student. We're going to cut through all the noise and give you exactly what you need to know for your exams and your rotations.
Okay, let's just dive right into a classic scenario. You are absolutely going to see this. Now, this presentation, it can feel a little overwhelming, right? But the answer to where do I even begin? It starts with one single essential lab test that's going to guide your entire workup.
And that test is the CBC. But look, it's not just a list of numbers you glance at. It is the first page of your clinical blueprint. If you can understand just a few key parameters on this report, you can build a really powerful differential diagnosis and start narrowing things down from the get-go.
So your first major decision point for any anemia is right here, the MCV. It immediately categorizes the whole thing for you. Are the cells small or microcytic? Are they normal-sized, normalcytic, or are they big, macrocytic? This one value is your first fork in the road.
Now you want to think of MCH right alongside MCV. It tells you about the color of the red blood cell. Are they pale or hypochromic? And that directly ties into the pallor you're seeing in your patient. So when you see small, pale cells on a CBC, a very specific group of common pediatric anemias should immediately pop right into your head.
So what's the deal with reticulocytes? Well, they tell you if the factory, the bone marrow, is responding the way it's supposed to. If the body's anemic, that factory should be churning out these baby red blood cells like crazy. So a low count when there's anemia, that's a huge red flag that you've got a production problem.
Okay, so with those CBC basics down, let's add the first major section to our blueprint, the anemias. And we're going to start right from the very first weeks of life.
You've got to know what's normal before you can spot what's not normal. All healthy term infants go through this expected physiologic drop in hemoglobin. It's just part of switching from fetal to adult hemoglobin. It only becomes a problem, it becomes pathologic, when that drop is way too severe or if you start seeing other signs of trouble, like jaundice.
Now this is your high-yield cheat sheet for exams. Seriously. All three of these conditions give you small red blood cells, but just look at what separates them. Iron deficiency, by far the most common, is going to have low ferritin. Thalassemia trait, on the other hand, has a crazy low MCV, but the iron panel is totally normal. And for lead poisoning, your PANCE buzzword is basophilic stippling. You gotta know that.
All right, let's switch gears. For the next part of our blueprint, we're moving away from red blood cells and into problems with stopping the bleed. So we're talking platelets and clotting factors.
Okay, for ITP, the crucial point, the word you have to remember is isolated. The only thing wrong on that entire CBC is a scary low platelet count. The kid often looks surprisingly fine, but they're covered in petechia and bruises. And the story is almost always that this started right after a viral illness.
And this just shows the difference perfectly, doesn't it? ITP is that superficial skin-level bleeding from low platelets. Hemophilia is deep bleeding because you're missing a clotting factor. So your key lab here isn't the platelet count at all, it's a prolonged APTT. That points you straight to a problem in the intrinsic pathway, which is exactly where factors 8 and 9 do their job.
Now for our final section, and you could argue it's the most critical one, how to spot the red flags for pediatric malignancies. This is where being a sharp PA can literally change a child's life.
Listen, if you're only going to have brain space for one pediatric cancer for your boards, this is it. Acute lymphoblastic leukemia, or ALL. It's number one, and its presentation is an absolute cornerstone of this blueprint.
And this age range, this is a massive piece of the clinical picture. When a toddler or a preschooler shows up with the right group of symptoms, ALL needs to be way up high on your differential.
These are the symptoms you just cannot afford to miss. What's happening is the bone marrow is so stuffed with cancer cells that it can't make any normal cells. That's what leads to the anemia, the low platelets, and the infections. And that bone pain, especially pain that wakes a kid up from a dead sleep, that is a huge red flag.
It's so important to get that the treatment for ALL is a marathon, not a sprint. It's broken down into these three really distinct phases, and the whole thing lasts for over 2 years. It's all designed to get rid of every single last leukemic cell, and, just as importantly, to prevent a relapse.
Okay, to round out the cancer section of our blueprint, let's talk about one key solid tumor you absolutely have to recognize when you're on your peds rotation.
And this is the key takeaway, the classic story, for Wilms tumor.
It's a healthy toddler, and a parent discovers a firm, smooth mass in their abdomen, usually while they're giving them a bath. The kid feels totally fine, but this mass is there. That is Wilms tumor until you prove it's not.
So wow, we have covered a lot of ground really fast. Let's lock in the most important points and put together the final page of your PA blueprint for pediatric heme/onc.
These 4 points, these are the cornerstones. If you can master these concepts, you're going to be in great shape for your exams, and more importantly, for actually recognizing these sick kids in the clinic. So, classify the anemia, know your bleeding patterns, think about leukemia, and spot that abdominal mass.
So I'll leave you with that to think about. Both are serious, for sure, but one of them points to a much more immediately life-threatening process that needs an urgent investigation, right now. Knowing the difference, well, that's the key to being a really sharp clinician. Thanks for watching.